Welcome everyone. We're just having everyone join us. We might just wait a few seconds to make sure that people are ready. We might get started. Good afternoon, everyone. I'm Emma Hoban, Manager for the Australian Centre for Value-Based Healthcare at the Australian Healthcare and Hospital Association. I'm joining you from the lands of the Ngunnawal people and pay my respects to their elders past, present and emerging. I would also like to acknowledge and pay my respects to the traditional owners of the many different lands on which we all are joining this webinar today and recognise their continuing connection to land, water and culture. Today's webinar is focused on understanding variation in healthcare and in particular, using data to identify and address low value care. Substantial variation in healthcare outcomes or processes demonstrates an alarm bell. It should make us stop and investigate whether the right care is being provided that delivers value and improves the outcomes that matter to the people and communities we serve. Variation in itself is not necessarily bad. When it reflects differences in people's needs, it can be an indicator of good quality healthcare. However, when it doesn't reflect needs, it is unwarranted and can represent the provision of low value care. It is estimated that up to 30% of healthcare is low value because it is either ineffective, harmful, or confers marginal benefit at disproportionately high cost. Low value care undermines the provision of value in healthcare. It results in unnecessary financial costs to services and to the system. It contributes significantly to the healthcare carbon footprint, and it can put people through unnecessary medical procedures that can cause physical and psychological harm. With waiting lists for healthcare growing rapidly in Australia and health expenditure rising unsustainably, there is an urgent need to identify clear examples of low value care, interrogate the drivers of it, and promote ways to prevent and disinvest from it. Today, we are going to hear from Gillian Giles, Director of the Healthcare Variation at the Australian Commission for Safety and Quality in Healthcare, Professor Adam Elshaw, Director of the Centre for Health Policy at the University of Melbourne, and Dr. Rachel David, CEO of Private Healthcare in Australia. They are going to discuss their experiences of using data to identify and understand unwarranted variation in the Australian healthcare system. If you have any questions for our panellists throughout the session, please use the Q&A function at the bottom of your screen, and I will get to the questions throughout our discussion. So now let's start by getting a sense from each of our panellists about the work they are undertaking to identify and understand unwanted variation and low value care. Gillian, could you tell us a little bit about the work of the Commission in identifying healthcare variation and supporting appropriate care, and why has the Commission identified this as a priority?
Thanks very much, Emma, and thank you to the whole team at the AHHA for organising this webinar on a topic that's very close to my heart. So I too would like to acknowledge that the past, current and future Aboriginal and Torres Strait Islander peoples are the continuing custodians of this country upon which we live and work. Here in Sydney, I'm joining you where the Gadigal people of the Eora Nation are the traditional custodians. So the Commission has been publishing the Atlas series since 2015, and a lot has changed since then. We're dealing with a very different context. There's climate change and there's the myriad of complexities in the health system since the pandemic that we're all dealing with. So I would argue then that we must strive now for healthcare that's not only safe and high quality, but it's also got to be appropriate and sustainable. And key to achieving this is the Atlas, which can be used as a tool to reduce low value care. A bit of context at the Commission, we're a government agency. We're jointly funded by the Commonwealth Government and every state and territory, and our remit spans the continuum from primary right through to acute care across both the public and the private sectors. And today I'm going to be discussing, I put our program areas on the right-hand side of the slide. I'm going to be discussing our second stream of work, which fits under our appropriate and sustainable healthcare stream. So in this era where climate change is top of mind, we must turn our attention to how we can minimise low-value care and reduce carbon emissions. Why focus on healthcare variation? As you pointed out, Emma, at the introduction, variation in and of itself is not a bad thing. And in fact, when it reflects differences in patient needs, it's the hallmark of a responsive and high-performing health system. But when it doesn't reflect patient needs, it's unwarranted, and that's a signal for us to improve the system. Sorry about that.
No, that's okay.
And I was actually going to suggest, do you want to swap to Adam while we wait for them and jump to Adam?
That's a good idea. Adam, do you want to jump in here and tell us a little bit about the evidence base in low value care and the research?
Absolutely, I'm happy to. I'm hoping I don't have the same problem, however, so let me know if my slides come up okay. Can you see those in presenter mode?
Yes, perfect.
Great, thank you. Again, I'm coming to you from Wurundjeri country down in the Kulin Nation in Victoria, around Melbourne. I did want to just point out I'm at the University of Melbourne as Director of the Centre, as Emma said. A little bit of background and context is the roles I play in sort of policy and in government. Most of the research I'm going to show you today has really been a applied research program with different players in healthcare throughout the time, last decade or so. I also want to acknowledge some key collaborators to my work. So Doctors Kelsey Chalmers and Tim Badgery Parker, both of whom were my PhD students and postdocs and are responsible for a lot of the analytics you'll see today, and two long-term collaborators, Professor Ian Scott from Queensland and Professor Sally Pearson from UNSW, who this work wouldn't be possible without as well. Just a quick bit of background. So I've been interested in this area for sort of 15 years ago. In fact, my PhD was really calling for the need for what is ultimately an MBS review, pointing out that there are policy challenges in Australia around how we identify and disinvest from low-value healthcare practices, which led on to us proposing certain ways to identify and prioritise those services, which was commissioned by the Commonwealth Government, which led into the first iteration of the MBS review. And since then, I've been sort of working on different areas of the problem, around quantification and levers for minimising low-value care and so on. Just an idea of some of the different papers that we've published over the time. So back to measurement, I think a nice introduction to the measurement piece really started mostly out of the United States over a decade ago. I mean, obviously this problem has been around much longer than that and it's been recognised for longer than that. But I think some of the more relevant work that has led to some of the modern day measurement has come out of the US and the chart review programs that happened. There are very few services out there that are truly low value for everyone. It's more about services having a high and a low value application. So this is an important principle for the work that we've taken forward. If I could see, sorry, some work looking at the insertion of automatic portable cardiac defibrillators in Florida and found that 22.5% of those were inappropriate when you look through chart review of different patients. Hannon looked at the New York State Cardiac Diagnostic Catheterization Database and found that sort of 25% were inappropriate and only 35% were considered appropriate. And there was this sort of grey zone in between of about 40% that were uncertain. Similarly, when you look at full thickness rotator cuff tears, 53% considered really appropriate. So this is a really nice way of conceptualising the heterogeneous aspect of effectiveness. So it's can be inappropriate for some and highly appropriate for other people. So my work in measurement for the last decade or so has been trying to take this, which was largely chart review, which is highly laborious, expensive, time-consuming, and see if we could automate it by looking at large databases. And we first started this piece when I was at Harvard Medical School doing my postdoc, and where we tried to develop a system where we directly measured these sort of high and low value applications of services within the US Medicare system, which we did. And the Choosing Wisely program, which many of you will be familiar with, was really key to this because this was the first time that clinical groups had come out and said, you know, for certain procedures, there's a published recommendation against using it. So don't use service S for patient group G, avoid service S for indication I. So this was a boon for this work because we were just taking the recommendations that came forward from the clinical groups and we were trying to code them up against inpatient data to see if we could measure the prevalence and trends and costs associated with these low-value procedures. All of the methods are published, so I encourage you to read through those if you haven't seen them. To give you an idea, it's important. One important part of our measurement work is that we measure according to the narrow and the broad definitions. And the reason we did that is mostly because from around the world, slightly different recommendations came out around the same service. So this is an example around carotid endarterectomy. You can see between the Australian Choosing Wisely and Evolve programs, the Canadian and the US programs, they're all kind of similar, but they all have different requirements around them in order to determine something as low value. So rather than us get into the debate about which of those are more or less appropriate, we would measure it according to a broader, which captures a broader population as low value, and a narrower. And you can see there that the narrower definition is exactly the same as the broader one, except for the red item. So once you include those red additions, then naturally you've got a smaller group. And the first piece of work we did around here was in partnership with New South Wales Health, which included a 30-member panel of clinicians who helped us to come up with these codes and map it against inpatient data. The first paper that we published was in BMJ Quality and Safety, which looked at New South Wales specifically, and we looked at prevalence and trends, costs over time, over a 7-year period. We subsequently went on to do the same program of measurement work for Victoria, Queensland and South Australia. And just to give you some idea, you can see that the measurements are very similar. So between the N and the B refers to the narrow or the broad. You know, the prevalence for these 28 services is quite similar between the different states, somewhere around 10% on the narrow and the high teens on the broader definition. And to give you an idea of what that actually means, so if we just look at one state and you look at the 28 services, the top section is looking at public hospitals. So if you have about 11% on the narrow and 17% on the broad, that's accounting for between 14 and 26,000 bed days, just for those 28 services as low value, so not insignificant at all. We also have done work looking at all the private hospitals, and again, if we look at the private hospitals across one state, same 28 services, it jumps up a bit. It's between 13.5 and 20%, which equates to about 20 to 35,000 bed days. That's for 28 services in 1 year across the hospitals. So back to public hospitals. So we also find that there's variation between hospitals. So every row that you're looking here is a different service, and the dot represents one hospital. So you can see, let's look, knee arthroscopy, which is everyone's favourite example, third one down there. You've actually got some hospitals on all the way to the left that are providing 0% low value care, but then you've got some outlier hospitals that are in the sort of high 50s and 60% of their knee arthroscopies are considered low value. And then just because you have a hospital that sits within this range, then that doesn't mean all of the doctors within it are on that point. So we also see a distribution around the hospitals where if a hospital is 50%, you might have individual clinicians who are 0% and others might be 100% as well. And we have that data as well. Rachel from PHI actually commissioned us to do a work looking at 4 of the largest private health insurance funds in Australia. I think it represented about 68% of privately insured Australians. Once we added them all together for the 4 funds, we looked at 21 services across the 4 funds, and the low value count ranged from about 111 and narrowed to about $200 million per year in 1 year. If you extrapolated that out to include the remainder funds, assuming they had the same proportions or prevalence of low value care, PHI is spending between $167 and $300 million per year on low value care for just 21 services. And we broke that down to a subset. It's important to state that just because people might be receiving a low value intervention doesn't mean they shouldn't be receiving any intervention. So if you think about these subset of people who should be receiving something else, you can still see that it's very high, somewhere between 150 and $273 million a year in 1 year of expenditure for just 21 services. We've done a lot looking at individual medical practitioners, both between and within variability, and by between, what we found in these charts, a little detailed, but I'll explain them. Essentially, we're interested in the top 5% of performers by volume. So for fund number 1 at the top 5% of volume practitioners are providing 12.3% of these procedures, but they're responsible for 43% of low value procedures. In the second fund, the top 5% are doing 9.7%, but they're responsible for 52.6% of the low value procedures, and so on. So this is really telling us that there's actually a smaller proportion of clinicians who are responsible for an outsized proportion of low value care. Interestingly, we've also done work looking at individual practice of one doctor between different locations and found that they vary quite a bit between hospitals. So in one hospital, they might be 0%. In the second hospital, they might be at 20. In the third, they might be 40 or 50 or higher, which was quite an interesting find for us. well as looking at prevalence and trends and costs, we are interested in the harm associated with low-value care. We published this piece in JAMA Internal Medicine, which measured hospital-acquired complications associated with low-value care, and we chose seven procedures for which the patient should have only been in hospital to receive a low-value intervention. So this is not a case where they should have received something else. So this allowed us to attribute the HAC only to low-value care. Overall, we found that if there was any HAC associated with low-value care, that it at least doubled length of stay. And for an arthroscopy, which quite stunned us, I have to say, if you had a HAC resulting from a low-value knee arthroscopy, it added 13.8 days on average to length of stay. So demonstrating that hospital-acquired complications, extended length of stay is a problem with low-value care as well. States are now using our algorithms to measure low-value care and developing dashboards. This is an example of just some simple dashboard systems where they're tracking low-value care over time, tracking HACs associated with low-value care over time, and also looking at different systems. So on the left here, each bar represents a system, which might be a group of hospitals, either an LHD or a LHN, so on, and the dot represents the procedure that is the outlier within that system. And you can see that across the systems, there are actually different procedures that are outliers. And then on the right-hand side, it just flips it around where the bar actually represents the procedure and the dot represents the system. So again, you can see on the example I've highlighted, most of the systems are huddled down to the left, and there's one all the way out to the right where 100% of the procedures are considered low value. And again, this is just looking at doctor variability within that as well, pointing out that individual clinicians can have an outsized impact on the costs and prevalence of low value care. I'm just going to jump quickly to some of the work we did on the MBS review. This is one example of a policy intervention around what was a very successful policy intervention. We were interested to look at 3 and 4 region spinal x-rays that on the MBS. There was between 15,000 and 20,000 of these being requested per month in Australia before we intervened. There were 4 groups who could request these. There were medical practitioners, chiropractors, physiotherapists and osteopaths who could request these 3 and 4 region spinal x-rays. When we looked at who was requesting most of them, there was one group of those 4 that was responsible for most of them, and we ended up having that group removed, having their ability to request these x-rays removed from the MBS, and that was the result that we found after having that removed. So this is an example where that there are interesting and innovative ways that policy can start to address low-value care. I'm going to finish on some unpublished data. We've done a piece of work. The first part has been published, but this is a sub-analysis. We worked with colleagues in Ontario and Canada and also in the US, looking at radical prostatectomy. And this is being measured by quintiles, income quintiles. So the bars on the left are the poorest all the way to the wealthiest quintiles on the right. So the light blue here is looking at New York public hospitals. The dark blue is looking at Ontario by lowest income quintile to highest income quintile. We looked at Australia and we broke it down by New South Wales public hospitals and New South Wales private hospitals. And I'm just going to ask you in your mind to have a think about where you think New South Wales sits, both overall but also in trend between public and private. The results shocked us. This is what radical prostatectomy looks like in New South Wales compared to New York State and Ontario. And you can see the proportions that are occurring in New South Wales public hospitals, which is the lighter shade of pink or peach, whatever it might be, versus private hospitals, which is the darker shade of red. So that's the quick presentation. So our measurement to date really has focused primarily on the prevalence, trends and costs associated with a subset of low-value care procedures. We've looked at provider variation and we've looked at some of the harms associated with them. Things that we're working on currently is measurement of what we want to measure rather than what we can measure. So the 28 services or the 21 services were largely practical. It was the ones that we could measure up easily within administrative data. But clinicians kept on telling us that it's really just the tip of the iceberg. There are other services which are higher priority, higher impact, which probably have a bigger impact on the prevalence and trends and costs of low-value care. So we're actually targeting those now, developing new indicators. We have done our initial analysis to look at what happened to low-value care through COVID. we hoped that it would drop off and we don't want it to return, but unfortunately the results are starting to indicate that that has not happened, and actually that low value care has returned post-surgical shutdown. We have new partners and new perspectives, so we're doing some really interesting work in partnership with Sierra at the moment, looking at workers' compensation and traffic accident cohorts to see the low value care that they're receiving, and some very exciting work now that we've looked at prevalence, cost trends and harms. Now we're adding the carbon footprint to the low value care, so there's going to be some interesting papers coming out very shortly on that work that we're doing. So I'll stop there. I think I've got about 12 minutes on my clock. So thanks, Emma. I'll hand back.
Thank you so much for that, Adam. That was really interesting. I think we've got Gillian's slides now ready to go. So Emma, are you able to share those? And we will get back into Gillian's presentation.
Thanks, everyone, and my apologies for the presenter view situation. So I'm in the safe hands of the AHHA now. So Emma, if we just jump straight to the third slide and I'll pick up from there. Thank you. So I talked about why focusing on healthcare variation. I have to say that Adam's presentation is a very nice segue into this one, because I'm going to pick up and echo a lot of the themes that he just raised. Unwarranted variation is what we're interested in today, and I know Rachel will be talking a little bit about some of the drivers of this, so whether it's system design or perverse incentives, clinician or consumer behaviour. But I also was keen on this slide to flag that we also need to remember unwarranted variation isn't always low value care. Equity must be at the front of our mind, and that's why I put inequity as that last dot point on the right hand side, because on the flip side of all of this, variation may well reflect the fact that people are missing out on the care they need. Next slide, thanks. So the point of examining variation is then to actually act on the data to improve the appropriateness of care. So we describe this in our appropriate care model as initially identifying variation. We're interested in whether it's how your healthcare varies between geographical areas across Australia or in fact internationally, between health services or even within health services. And we're also interested in variation from evidence-based guidelines. I was at an OECD work, and then moving on from that, this slide, we then want to investigate that variation as to determine whether or not we need to distinguish unwarranted from warranted variation. And then finally, the whole point is to then respond by improving the appropriateness of care so that we're delivering care that's in line with evidence-based guidelines. And I was at this OECD workshop last week on sustainability, so the role of health policies in tackling climate change. And there's such a myriad of work, different types of work underway in Australia and around the world on how we are working towards a greener health system. So it varies from complex carbon life cycle assessments through to using renewable energy sources, reconfiguring procurement to use supply chains that have a lower carbon footprint, and looking at measurement and indicators of the environmental footprint of health systems. But I always say the very first thing and the most obvious step in all of this, as Adam said, should be avoiding unnecessary care in the first place. So minimising low value care and reducing waste. The next slide, thanks. So the role of the Atlas series in all of this is to identify potentially unwarranted variation. And we're interested in the causes of this. And that can be, we can pick up some of these themes at a national level. Some of these themes will be what local health services distinguish. So differences in clinical practice, gaps in evidence, inequity of access, and inadequate system supports for appropriate care. So the whole idea is that examining variation is about using data to drive improvements in care and outcomes, so that it can help us to better understand healthcare delivery and reduce low value care. So I've put some of the purposes or the role of the Atlas series up there. So firstly, it's a tool to direct health systems to provide high value care, so that they're ensuring that all of their resources and systems are focused on what counts most. The Atlas also it requires a systematic measurement of healthcare variation and monitoring and responding to unwarranted variation. This is that framework I mentioned about appropriate care. We've also directed health services to focus on variation through the National Safety and Quality Standards. So it's a requirement of the governance standard. Action 1.28 means that every health service in the country, private or public, day procedure services must be monitoring variation and then responding to unwarranted variation if they find that's the case. Fourthly, it's so important, we've got to keep the spotlight on equitable healthcare. We're far from resolving that issue. But the fifth point is the one I just wanted to spend a bit of time on. It's a new concept for us that we're going to be developing more guidance on. The importance of promoting a culture of stewardship. So this concept that we have shared finite resources in the health system, that's not a new concept. But our current approach is unsustainable from a cost perspective, from the workforce perspective. We've got this continuing inequity, and now top of mind is this enormous carbon footprint. So adopting a culture of stewardship within at an organisational level, something that's ideally driven by the board and leadership teams, means that we can lead reinvestment from wasted resources to higher value interventions, and therefore focus on low value care. That's the next slide, thanks. So the product, what is it that we actually publish? So the Commission partners with the AIHW to extract and analyse the data. And then because we're geared up to translate data to action, we combine many different elements in our Atlas series to help do this. So we publish not only the data, but we have our visualizations, we have expert commentary, and we write recommendations for action. We used to publish large compendium-style atlases, so spanning many, many topics, and we've now evolved that to focus on more targeted reports with time series data, where we're spending just as much time engaging with the system as we are in producing the reports. And the one thing I want to flag on this slide is that it's important to keep front of mind is that we map our data by a patient place of residence. So therefore, this is not a measure of health service performance. It's instead we're flipping the focus onto the provision of appropriate care. So it's about who is receiving care. Thank you. Next slide, thanks. So how do we do this? That's our product. What's our approach? I've called it the Atlas Plus model. So we consider impact at the outset, and we craft our design to achieve this. And we do this through 3 different ways with our partnerships, our levers for change, and a local level response. The next slide, thanks. So the first element to all of this is that we work with a cast of thousands. It's a very collaborative process from conception right through to publication. And we engage high-profile contributors when we select Atlas topics as well as develop the content. And that's because this creates advocates and clinical champions who can then are in a position to act on the findings. If you click again, thanks. The project governance here is also carefully considered. We have advisory groups spanning all states and territories. We have public and private sector representation, consumer advocacy groups, policymakers. The media has been very helpful to us over the years. For each of our 4 large atlases, we always had the health minister launch the atlas, which generates a lot of media, which has been helpful in building the case for change. And then now we're looking at sort of this more bespoke tailored model where we're finessing the way we provide data, not only at a national level, but also then at this tailored level, at a local level, in order to affect change. Next slide, thanks. The second element after partnerships is the levers for change. So systems thinking underpins everything that we do. We're interested not only in the different parts of the system, but importantly, how they interrelate and the impact of one upon the other. And Adam talked about some of these, particularly the financial one. So for example, when we found wide variation in potentially preventable hospitalisations for chronic disease, we made some recommendations about funding models, which led to work with the National Funding Agency and with the National Health and Pricing Authority on bundled payments and a pilot there. Clinical guidance is another lever, is powerful. So we have our clinical care standards program in the Commission, who prepare standards that define what appropriate care looks like. An example of that would be hysterectomy, where we found a difference in rates of hysterectomy in rural versus metropolitan areas for women. And so our clinical care standards program developed a standard on heavy menstrual bleeding, which described alternative and less invasive treatments to hysterectomy. And then accreditation I mentioned, which is a fairly powerful lever. If you click through again, thanks, Emma. I wanted to then focus, picking back up on the thread that Adam started with about knee arthroscopy. So arthroscopy procedures are not effective for treating knee osteoarthritis. In systematic reviews, trials involving middle-aged to older patients with knee pain caused by osteoarthritis showed that arthroscopy provided inconsequential benefit in pain relief, and it's in fact offset by increased harms. So in our first atlas, we found a 7-fold variation, and if you can click again, in knee arthroscopy across the country for people aged 55 and over. So we referred the findings, we used the financial levers to the MBS Review Task Force, which Adam was on, and they subsequently removed funding for knee arthroscopy for degenerative knee changes. We developed a clinical care standard on osteoarthritis of the knee, and then in our partnerships we worked with states and territories and local areas to talk about their rates, and there was particularly high rates in one state and in one particular capital city, and working with that Department of Health, they then drilled down into their own data and found that this practice was very much influenced by some sports medicine clinics in the area, and they then worked with orthopaedic surgeons to show them their data. And the result of all of that is that we've seen a great reduction, which is obviously not just due to the atlas. There's been many other things happening in the system at the same time, but so pleasing to see this drop by 46% between 2014 and 2020. Thank you. Next slide. And then the final element here, the third element, is this local level response. So the Atlas Plus model is not prescriptive, rather it's a signal for the system to show areas requiring further investigation. So we're all about supporting local leadership teams and clinicians to investigate, monitor and respond to their own data. This is partly because we're constrained at a national level by the caveats of the administrative data that we're dealing with, but on the other side to that, we're publishing data which health services otherwise wouldn't have access to, and this enables people to look at their data in a very different way, stick your head above the parapet and see how you compare to other areas. So if you click again, thanks Emma. An example to talk about here is we've published a clinical variation user guide which supports health services in how to tackle variation. I'll step through that in more detail. And then a click again will show us then an example of a local health district, a nice example of a response. Local health district in Sydney, a very large one, has established a healthcare variation executive steering group which reports to the board. It's comprised of heads of department, and I really like this model as a way of embedding variation and appropriateness of care into your governance frameworks. Okay, next slide, thanks. I'm going to jump through fairly quickly our user guide. I've put the link there. You can see this on our website, which is we've described how you can monitor and address unwarranted variation through 6 steps. And then the next slide, I wanted to point you to a case study. We've got a bank of case studies also on our website that showcase different approaches to how people have used these steps. And I'll refer you to the website rather than spend time on this case study, other than it was a fantastic example by Safer Care Victoria in responding to Atlas data, which showed that we found considerable variation rates of tonsillectomy across Australia in our 4th Atlas. And of note, 6 of the 10 local areas with the highest rates of tonsillectomy were in Victoria. And so Safer Care Victoria then also looked at their own data and were concerned about rates of unplanned readmissions after tonsillectomy and adenoidectomy, and developed a really fantastic project about how to address this. They explored some of the reasons for variation in the literature and found that pain management was often quite a significant factor in readmissions. And so they worked with their pilot sites to develop some guidance for parents and clinicians about the pain management. There's a whole lot of other things too, which you can read about on our website. But the outcome was that after this project, the median weekly readmission rates for the 5 pilot sites fell from 4.2% to 0% between January and March 2020. And there were also other beneficial outcomes in terms of high levels of family satisfaction, increased clinician awareness of how best to support families, and high quality resources that were able to be tailored by local services. So I'll end with a quote from Associate Professor Gillian Nixon, who was the clinical lead for the project. She's a paediatric respiratory and sleep physician at Monash University. Everyone in the project was motivated to try to make things better. People from different sites appreciated the chance to take time out from their clinical roles to talk to colleagues in similar roles from other hospitals. For example, we had nurse unit managers from a medium-sized public hospital, from a regional hospital, and a big private hospital. They had so much in common as professionals and could learn from each other. It's a terrific illustration of addressing low-value care. So to conclude, I hope I've convinced you that high-value care is low-carbon healthcare, and that the Atlas model can be used as a tool to work towards this and to reduce low-value care. Next steps for us is we're focusing on governance, as I mentioned, and guidance and support for boards and leadership teams on the delivery of appropriate high-value care. And ultimately, we want to create a culture where we can shape appropriate care at a local level. It needs to be top-down, bottom-up, middle-out, so that there's a shared commitment to delivering appropriate and sustainable healthcare. I'd like to acknowledge my team. I'm continually inspired by my colleagues in the Healthcare Variation team, who are strategic and deep thinkers, and this body of work reflects their combined talents. And now I'll hand over back to the AHHA, and I'm keen to hear from Rachel. Thank you.
Thank you so much for that, Gillian. That was an excellent presentation. So now, Rachel, can you tell us a little bit about what you have observed and what some of the system drivers are that we could be using to address unwarranted variation and low-value care?
Sure. I'll start again by acknowledging the traditional owners on the land from which I'm actually joining the meeting, which are the Gadigal people of the Eora Nation, and acknowledge their elders past and present. I just wanted to spend a minute refreshing you guys' memories about who we actually are. We are a peak body. We're a lobbying organisation, a policy and advocacy organisation that represents health insurance funds in Australia. We represent 98% of that sector based on membership, so roughly 14.5 million Australians. And those members really are the focus of our advocacy work. So whereas we acknowledge the amazing role that our providers, doctors, nurses and hospitals offer the sector, our number one objective is to protect the interests of our members. So that's that 14.5 million Australians. And therefore, logically arising from that, helping the rest of the population access the health system as well by taking a bit of the pressure off. So we have the traditional policy and advocacy role, but we also do an enormous amount of negotiation with other stakeholders about what care actually does get funded. And increasingly our organisation is doing research, and it's not just market research, it's now going into clinical research where we're sharing data for some of these big projects, looking at some of the effectiveness and cost effectiveness of some of the procedures and interventions that we are actually providing. And we're increasingly being asked to do that by clinicians in academia, so we can start to evaluate the real effects of some of the treatments that we've been funding in some cases for many years. I also, if you can just flick to the next slide, I'm just getting the AHHA to drive. Why is this important? Private health is actually growing quite rapidly as a source of funding and a choice of Australians, particularly over the last few years. We've gained about 1 million members since March 2020, and we expect that trend to continue. I won't go into the reasons related to different demographics in the workforce and different choices now being made by skilled migrants and so forth. But we are going to see over the next few years a situation where easily 2/3 of all surgical procedures and over half of all mental health admissions are going to be funded by private sources in one way or another. So that is going to continue. And, because of that, we have a responsibility to make sure that those procedures and interventions are high value and are actually delivering for patients and delivering what they expect. Next slide, thanks. So look, I thought I would go into some of the drivers, and these are in no particular order, because I think it's very important that we do not engage, no matter how tempting it gets, in the blame game. This is not an exercise in blaming doctors. They might be the drivers for some of this, but certainly the behaviour of doctors is not the root cause. It's also not a kind of exercise in private versus public, which is better. We actually work hand in hand with the AHHA and the state governments and public hospitals to try and address the issues around low value care. We're not competing with them on this issue. And I don't think it's particularly helpful to kind of point the finger at one corner of the sector and say that they're driving all the low value care, because it's just not borne out by the data or by fact. So some of the issues that we come up against, there are so many factors here that actually drive low value care. And one issue is there's a lot of stuff that we've done because we've always done it in the sector, or we've been taught to do it, that's just never been evaluated. So that's the first thing. It's actually quite poor cost effectiveness evaluation of some of the older and more established procedures. Now we're starting to look at some of this in situations where red flags have been raised in publications or as a consequence of the data that we see. And one of the issues that we do have is sometimes these things are not visible to a doctor treating an individual patient or a small cohort of patients. But when we look at the data overall, a different picture starts to emerge. And one of the areas in which the sector is very active at the moment, working with academics, clinicians, and people like Adam, is in some of the treatments that we've used over the last couple of decades for low back pain that are now been shown to be no more effective than placebo. One of them is being the subject of a review by the TGA and the Department of Health at the moment. That's the use of neuromodulation technology in the treatment of low back pain. This is an extraordinarily difficult area, but it's a very good example of how something that was used for a long time has been shown over time not to be cost effective or high value. There are a lot of consumer issues that we deal with here, and a lot of consumer-based rules of thumb that signal the need for a lot better education and a lot better focus on health literacy. So you still hear a lot of things from consumers around newer is better. I've been told I'm getting the latest treatment, therefore it must be better. The more you pay, the better the outcome. And we've seen some very tragic and sad examples of this, where people who are in the last stages of their life with things like brain tumors and terminal conditions have been talked into paying enormous amounts of money because the belief is that will secure them some extra years of life, and in fact the reverse was found to be the case. And the overall belief with surgery that interventions are more effective than conservative management. So it's a particular issue when weight gain and metabolic conditions are an underlying cause of some of the symptoms and signs that a patient is experiencing. The diet and a graded exercise program and so forth is hard. It takes a long time. You need sometimes multiple allied health professionals involved, but a quick fix of, oh yeah, I can have a look at that knee and do X, Y, and Z might seem to be a lot more palatable. So there's a lot of issues around surgery from a consumer perspective, and we've seen our colleague Professor Ian Harris write a book and with his colleague Rochelle Bookbinder around these issues, but also a book that focused in on the placebo effect of surgery. So a lot of people are very influenced by the process of treatment, but that doesn't necessarily mean the treatment has been effective, particularly in the long run, and that can be a very difficult issue for clinicians and their patients to unpack when in fact it's revealed in the data. Inappropriate pricing can create a perverse, or it does create a perverse incentive. This is an issue where the Department of Health is definitely a stakeholder, and we've had to work very hard to ensure that the processes at that level are not subject to regulatory capture and lobbying by just the person with the biggest pockets in the room. This has been a real issue with the evaluation and pricing of some of the medical implants and surgical supplies that were funded via the prescribed list of the Commonwealth prescribed list of medical devices. And then we have issues around medical training and the diffusion of data and clinical evidence into practice. You know, there's a saying, a sort of a rule of thumb, which I haven't really got data for, but it's sort of been around for a while, that, you know, it takes 6 months sometimes for clinicians to be introduced to a new technology and start using it. And if it's found to be ineffective, 17 years for it to be removed from practice. There are a lot of reasons why that occurs, but I think it's really imperative that the concepts around cost effectiveness, health technology assessment, and real world evaluation are taught from the get-go in medical schools and nursing schools and to all health professionals, including the patient consent aspects of this, that, you know, you really need to take some time to establish what the patient's goals are, and Rochelle Buchbinder has written extensively on this, but taking the time to have that conversation about what the patient's goals are and ensure that, you know, what you're proposing and its likely outcome actually is going to meet those expectations and goals. That can sometimes be a difficult conversation to have. It takes time. You need to actually elicit from the patient what they're trying to achieve through seeking medical advice and interventions, and sometimes it can be a very emotional and difficult conversation, particularly at the end of life. But it's definitely something that needs to be taught, and not just in a theoretical way. I mean, I can tell you that throughout my career, which has been in medicine and economics, I've learned statistics at university. I've done courses in university, statistics and data analysis in university maybe 3 times. You know, I know how all of this works in theory, but when it comes to actually talking to someone in front of you, it's a very different skill set. And then the final point I make here is about fragmentation. You know, when you're a hammer, everything looks like a nail. And I know that's a kind of crude analogy to bring to medical practice, but, you know, we have a lot of issues where someone's referred to a particular specialist, and so all the solutions that are offered to them are through the lens of that specialty, when in fact the root cause of what's going on for that person might be quite different or a broader issue. And have a look at the next slide, thanks. So I just wanted to go into one of the complexities that we face here, and that is a high value procedure can be turned into a low value procedure by systemic issues that may have nothing to do with the patient or the treating clinician. So just to use an example of something that we know in the right circumstances as high value care, and that's a hip arthroplasty, a hip replacement. The technology's been around for decades, and we've had some really brilliant results for osteoarthritis of the hip. It's one way in which private health insurance has been shown to have really high value, because we do these operations well in Australia, standard care. But, you know, you think about it from another perspective, how can that possibly be turned into low value care? So imagine the patient that's selected is a frail aged person who's obese and has dementia. Their goals of treatment have not been discussed, nor have they been appropriately discussed with the family. During the patient's surgery, the clinician uses an implant not based on data from the AOA National Joint Replacement Registry, but because the hospital and because they've received a free training course overseas from the medical device rep in another product, and the hospital's received a rebate on the basis of purchasing from that supplier. during the procedure, there's a sales rep present who is paid commissions based on how much they sell. So they are constantly introducing glues, hemostats and sealants into the procedure that wouldn't otherwise be used. In fact, not all of them are used, but the caps are taken off. So that toxic waste then needs to be disposed of in the environment when there's no evidence that even using it in the first place would have improved the outcome. The patient then spends weeks and weeks and weeks in rehab, during which they contract COVID and are readmitted to hospital. So this is the sort of thing that we're trying to avoid. It's not just procedures that we know already are probably useless, like arthroscopy of the knee or neuromodulation for the treatment of low back pain, but it's training our health professionals and having a sense of this, that everyone in the system is pulling in the right direction to avoid the sort of outcome that I just raised. Final slide. Just flick to the final one about what we can do. So look, I've got a few suggestions here. We work very hard in this space because we need to ensure that, you know, our funding comes out of the pockets of those 14.7 million people, many of whom are on low annuities, low incomes, and are really struggling with the cost of living right now. So we can't afford to be wasting $1 on anything, let alone low value care. So we've made a few suggestions, but I think the main one is that everyone in the sector needs to be aware of these issues and be pulling in the same direction. Learn to use the data, be pragmatic, and leave the ideology and the blame game at home. We have some excellent tools at our disposal when it comes to data analytics, and we need to be sharing that information and the tools we've used, like the Atlas, which has been an amazing tool and innovation that's used in Australia. But we need, again, and this includes organisations like the Federal Department of Health and State Departments of Health, that when we see red flags, we need a coherent, clear process to disinvest in a timely fashion in things that we know are low value and in some cases are actually causing harm. This is not something that should take decades. And patient safety, and nor should it be something, by the way, where we wait and wait and wait and wait till the plaintiff lawyers get involved and we're in court, like what happened with pelvic mesh. There's always going to be objections to disinvestment from some section, albeit small but noisy, in the community. But having a coherent evidence-based process to undertake disinvestment is really critical. And I just want to leave with a final point, is that consumer health literacy and better medical education on these issues and the concepts involved are really critical. From year one of health professional training, and with consumers, we need to do a lot better about educating them about how to evaluate the options, what's put in front of them and what they might find on Google in relation to their healthcare. So I'm just going to leave it there. I think I've probably maxed out my time.
Thank you so much for that great presentation, Rachel. Really appreciate you taking the time. So we've only got 5 minutes left for questions, so we might try and run through a couple quickly. First one we have here is, surely clinicians, doctors in particular, are keen to reject low-value care, but despite best practice guides, as a group, they often seem impervious. Are you, or is there any work that is being done to tackle this problem? Is it a matter for better undergraduate or postgraduate training, or is there other work that's being done? Rachel, did you want to start with this one?
Yeah, look, I think that we actually have had some good results when we've worked with medical colleges and provided direct-to-clinician feedback, as well as integrated some of the findings into medical training, but it can be complex and it takes time. I honestly think with arthroscopy of the knee, it did, I mean, actually providing feedback and talking about it did, and some very specific interventions with particular groups where we'd seen variation, when we'd seen use of that procedure spiking, it actually really did work. But it does need to be matched by some grunt from the regulators as well. I mean, honestly, there is no point in us doing all of this, if the MBS continues to, and the prescribed list continues to provide above or supernormal financial incentives to continue with low value care. So it's why it needs to go hand in hand with a coherent and evidence-based disinvestment process by our regulators.
Thanks so much, Rachel. So we've only got a couple of minutes left, so I might just do one final question to the panelists. If you had one piece of advice for people to support the better use of data to identify and address unwarranted variation and low value care, what would it be? So I might start with you, Adam.
Thanks, Emma. I think I'll point to one of Rachel's comments in her presentation. The reason I've been so eager to work across all payers and providers is because this is a system-wide issue. I think saying that, this only happens in private, doesn't happen in public is inaccurate and unhelpful. So I would encourage everybody to think about a linked up approach to data, to think about how patients travel through the system from primary right through to tertiary care, and understand the journey and understand where the high and low value points of care occur across that entire journey.
Gillian, did you have a piece of advice that you would give to everyone?
Sure, it's a great question. I think this all relates back to purpose and governance of your organisation, and that helps you to prioritise whether this is the importance of this issue for the entire workforce. So I would align it with risk and strategy so that there's organisational buy-in, and as Rachel talked about, all of that alignment of different programs of work, I think is really important.
And finally, Rachel, did you have any comments that you would like to add?
Yeah, I think we've got some great tools and analytics available, and I think we need to use them to communicate with clinicians and consumers in a friendly way, rather than just, with some charts and spreadsheets and stuff that might be pretty impenetrable to someone without a background in public health or statistics. And, I think there are so many ways we can start to do that now, and we need to make much better use of those tools.
Thank you so much to everyone. That brings us to the end of our time today. So that brings us to the end of our webinar, Understanding Variation in Healthcare Using Data to Identify and Address Low Value Care. Thank you so much to all of our panelists for your fantastic presentation. Unwarranted variation in low value care is an area of particular interest to the Australian Centre for Value-Based Healthcare and AHHA, and one that we will be continuing to explore over the next 12 months. So if you would like to keep informed about the work as it progresses in this area, please subscribe to our mailing list on the AHHA website. Thank you again for everyone for joining us today, and we look forward to seeing you again at one of our upcoming events or webinars soon.